paper is about the refractive outcomes of toric ICL. Myopic astigmatism presents a unique challenges due to its combined refractive components, thereby resulting in compromised visual acuity and patient dissatisfaction. So the toric ICLs provides precise correction of both the errors in single surgical procedure. Aim of the study is to evaluate the visual and refractive outcomes of toric ICL for myopic astigmatism. There is no financial interest. Methodology. It was a retrospective analysis of 125 eyes who underwent toric ICL implantation for correction of myopic astigmatism in a tertiary care center. Preoperative, intraoperative, postoperative data were collected and analyzed. The following assessment like visual acuity, slit lamp examination, corneal topography, pachymetry, individual cell count examination, intraocular pressure, axial length and antichamber depth was assessed in all the patients. After the consent, all the procedures were performed by a single experienced surgeon. Toric ICL power and sizing was calculated using online calculator. The toric ICL was implanted through 3 mm clear corneal incision under topical anesthesia. Post-operatively, ICL position and element were confirmed. Patients were evaluated at 1 week, 6 months, 1 year and annually for up to 3 years. Inclusion criteria. Those with myopic astigmatism between the age of 18 to 48 years with spherical equivalent of -3 to 20 with a refractive cylinder power of up to -6 who had at least stable refraction for 1 year with antichamber depth of more than 3 mm were included in the study. Those who had glaucoma, any corneal abnormalities, uveitis or retinal pathologies with the chamber depth of less than 3 mm with poor compliance were excluded from the study. Results. There was a significant improvement in the mean spherical equivalent refractive cylinder. Also the mean cataract distant visual acuity pre and post operatively. Also the patient had 6/6 vision. It was preoperatively 55% and improved to 89%. The efficacy index, it was 1.2 indicating it was excellent. It had excellent visual outcomes. Regarding the safety and stability, in this study there were no intraoperative or postoperative complications. Endothelial cell density remained within the safe limits with no significant decline. There is no significant changes noted in the antechamber depth and intraocular pressure. Discussion. Toric ICLs effectively correct both the spherical and cylindrical errors significantly. These findings demonstrate this procedure is safe, effective and stable option for correction of high refractive errors. Toric ICLs preserves the corneal biomechanics, thereby reduces the risk of ectasia unlike corneal refractive procedures. It is reversible and can correct high degrees of astigmatism. Conclusion. It is safe, effective, stable. It is a reliable alternative, particularly in patients not ideal for refractive procedures, cornea-based procedures. Precise transformative solution offering long-lasting vision improvement and high patient satisfaction. These findings support its continued use in clinical practice. These are my references. Thank you.
Thank you. It was well presented, I would say. The only thing is that it was a result of toric ICL implantation, which is being done for I think many years. So anything new that you could figure out in this? Any maybe in evaluation you can do that. Maybe different anterior chamber depth vis-a-vis requirement of rotation or anything. I mean, something that is new that you could.
So only with the manifest refraction, we were finding whether the rotation was there, sir. Only with the manifest cylindrical refraction, we were monitoring the patients.
So how did you check for ICL rotation post-operatively up to 3 years? How did you check?
Only with the manifest refraction. Manifest.
Okay.
So how many eyes did you have the rotation and required re-rotation?
Nobody required, sir.
Nobody required.
Mostly nobody required, sir. Nobody underwent resurgeries also, sir.
Okay.
For ICL rotation.
Okay. Okay.
Toric ICL itself is a very stable and very reliable kind of phakic IOL. So
only thing they complained was initially they had halos, ma'am.
Some patients, yes.
Only that they had and it's subsequently sub-zero also.
We just want to ask anything specific pertaining to toric ICL you want to highlight in your presentation, because this is all pertaining to ICL as well. So anything specific you want to add regarding toricity, or maybe sizing relation to the size of the ICL, or anything, calculation of the size or anything else?
Did you look for the axis of the IUL after surgery dilatation?
That's all.
You have only written refractive error.
Only
That's
one,
what she
within
said.
1 hour in the theatre itself we used to see, sir, in slit lamp, nothing else. After that we didn't see, sir. That marking we used to see within 1 hour, sir. After
No,
that
no.
we did not.
After, on your follow-ups. 1 month, you've written multiple follow-ups. Any of the follow-ups, the first month or 3 months, did you look at the position of the axis of the implanted lens vis-a-vis the preoperative axis?
We did not measure properly, sir.
I think that is something that's must for any toric lens.
Okay. Thank